Thanks everyone for joining us. We're gonna let folks come into the room and then get started in a minute or two. Okay, I'm going to get us started while people continue to come in the room in the interest of time. Thanks everybody for being here today. I'm Christy Giuliano, the Executive Director of the Big Cities Health Coalition. Gabby, let's go to the next slide, please. Thanks. The Big Cities Health Coalition is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of nearly 62 million Americans that our member health departments serve. So let's go to a housekeeping slide and then, okay. So this session is being recorded, just so everybody knows. All of the lines are muted except for the speakers. You can use your raise your hand feature or chat Gabrielle Nichols in the chat if you're having any technology issues. You can also share questions in that chat box as well. And this will be recorded, as I said, and it'll be up on our website for future viewing. So I'm so excited today to have Dr. Oxiris Barbot here with us, the Commissioner of the New York City Department of Health and Mental Hygiene. She has been the Commissioner for 2 years now, 2-ish years.
I'm really.
And then before that, served as the first deputy commissioner and at the department and oversaw the development and implementation of a number of agency priorities, including Take Care New York. Dr. Barbot has over 25 years of experience in advancing health equity and providing health care in urban communities. She previously served as Commissioner of Health for the city of Baltimore. And before that was a medical director in New York City Office of School Health. Dr. Barbot was the chief of pediatrics and community medicine at Unity Healthcare, which was a federally qualified health center in DC, close to where I sit today. She has a bachelor's degree from Yale and a medical degree from the University of Medicine and Dentistry of New Jersey, and did her pediatric residency at George Washington University here in DC, my undergrad alma mater. So thank you so much for being here. Really happy to see you. We're gonna pull the slide off the screen so that we can chat. So we're here today to talk about COVID-19, but you know, we also, I think, can't ignore what's going on right now in the country with protests from coast to coast after the killing of another Black man at the hands of police. As health commissioner in the country's largest city, what are your reflections on racism right now in the country?
You know, Chrissy, I think like a lot of us, I have been reflecting on what we're living through, not only through what we're seeing played out with COVID-19 and the racial inequities, but certainly what's been happening across the country as a result of the torture and murder of Mr. Floyd. And, you know, for me, the way I look at it is we are suffering a collective moral injury. And, you know, moral injury is a deep soul wounding piercing of our identity, of our sense of morality, of our relationship to society. And that I think that for many of us, there's a sense of losing confidence in the capacity of others to behave in a just or ethical manner. And that when we have these persistent, violent episodes occurring at the hands of, or in situations where there obviously is a very skewed power dynamic, it plays out in a way that is, I think, very challenging for us, and to put it mildly, right? I mean, I think it's normal for us, and I have a meeting with my staff tomorrow, a teletown hall, where, we're going to talk about what we're feeling. And part of what I'm going to say is it's normal to feel angry, to feel despondent, to feel like, our efforts have gone for naught. But I think at this point in time, with the way in which the various levels of racism, both interpersonal as well as structural racism, are playing out, it's ever more important for public health to tap into that anger, to tap into that righteous indignation, and to push ourselves, to push our leaders to lead even more with racial equity, both in the immediate period through how we respond to COVID-19, but even more importantly, how we exert our muscle and our role and our expertise in public health in the recovery period. Because unless we push ourselves and push our leaders to put into practice what our data has told us about inequities for generations, and we're just going to be back in this same place. And I don't think any of us could really tolerate that any longer. And so, I think just kind of summarize it a little bit more is to say it's been a period of soul searching. It's been a period of acknowledging our shared humanity, of our shared rage at what continues to happen, but of not losing hope or faith in really the power of our collective humanity. And that when and if we lose that, then we will be in a much worse place. And so I have been waking up every day even more determined to lead this agency through an equity lens, and even more determined to speak out from a public health perspective, from a human perspective, about the degree to which racism plays out not only in the immediacy of COVID-19, but through the inequities that are driving a lot of what we're seeing with regards to COVID-19, which I think, we'll talk about in subsequent questions. But there's a lot there to unpack.
So, we've talked about this before. Lots of people right now are talking about racism as a public health issue, right? And we work in a field where many things can be a public health issue. But so what does that mean to you, and sort of thinking about a public health approach to racism, and, leading one of the largest health departments in the country? What do you see as your next steps in thinking through addressing racism through a public health lens?
For the past, I would say 4+ years, we have engaged in a process through the agency on undoing racism. And we as leaders, we through various levels of our staff, have undergone a number of trainings with regards to undoing racism. We have really interrogated what it means to do public health from an equity space, and acknowledge the degree to which our institution, well-meaning as it is a part of a larger machine that contributes to structural racism. And so looking at how we, both from an internal facing perspective as well as an external facing perspective, can better operationalize an equity approach. And so for what that means for us internally, is looking at, for example, our hiring practices and ensuring that, you know, our staff is reflective of the city we serve, and that it's reflective not only in its totality, but especially in its leadership. And, you know, as a Latina, I take that very seriously in terms of the way in which I lead this agency. It also entails looking at, for example, how we do our contracting, how we secure companies that are minority and women-owned businesses, so that we continue to contribute to the way in which there's sustainability of economic development in our communities. We've looked at the ways in which we translate the way in which we talk about things, right? No longer using stigmatizing language that perpetuates racist tropes about the communities that we serve, and really focus on using language that comes from the space of strength rather than the space of deficits. And so it has been an iterative process for us. I wouldn't say that we are anywhere obviously near being done, but I would say that we have learned from our brothers and sisters in other health departments across the country, other members of BCHC who have been much farther along than the New York City Health Department. But I'm really proud to say that even though we were laggards in getting started, I think we've accelerated the degree to which we've adopted many practices that not only have transformed the way in which we talk about race internally and racism and structural racism, but the way in which we show up in spaces with community partners and the way in which we collaborate and provide guidance to our sister agencies. Because, you know, in this struggle, it's not just about what public health does, but it's about what we do in collaboration with our sister agencies to really dismantle racist structures that have been put in place that have given us the kind of outcomes that we struggle against every single day.
I don't think any of your colleagues would say you were late to the party on thinking about health equity as a health department. So let's bring it back around to COVID. So how would you say racism has affected the pandemic and the outcomes that we're seeing in this pandemic?
You know, I think, Chrissy, there have been a number of ways in which racism and structural racism have played out in this response. And I think I'll break it up into a couple of different categories. You know, first and foremost, it comes down to our data and the completeness of our data, and the fact that we early on were unable to give a complete picture of how race and ethnicity were playing out in terms of the number of people that were tested for COVID, the number of people that were hospitalized for COVID, and the number of people that were dying because of COVID. And, you know, the underlying reasons for that were because our partners in healthcare delivery, right, and the data that we're drawing from haven't prioritized race, collecting data on race and ethnicity to the degree that we have, right? And so as a person who had done clinical medicine, I know for a fact that in clinical medicine, you know, we would fight against incorporating race and ethnicity because we didn't want to seem as though we were racially profiling our patients and perpetuating racist tropes. But the reality is that from a public health perspective, race and ethnicity have everything to do with the way in which outcomes fall out. And if we don't take those measures into account, we will always be behind the 8 ball in terms of having timely responses to ensure that we are saving as many lives as possible. So for example, in COVID-19, we did something that was unprecedented, right? We released data before it was complete. We saw that we had data that was already, even though it was only half complete with race and ethnicity, was already playing out the disparities that Black and brown people were being more affected and that they were dying at twice the rate that white people were. And so rather than wait until that data was perfect, which is usually what public health does, we had an obligation to make sure that that data got out as quickly as possible and take whatever heat we needed to take, right? Internally, and my staff was like, we can't release data before it's ready. And then externally, our partners saying, what took you so long, right? And so I think it was the right decision, and it was a decision that helped us to then shed light on the fact that we need our partners in healthcare to pay more attention to this, and that we then need to use that data to start better directing resources to a place-based approach as we fight COVID-19, right? And so on the more response-oriented side, it certainly highlighted issues for us with regards to, you know, the placement of testing centers in communities of color that were being more affected. It certainly created a stark picture with regards to how we define essential workers and where they tend to live and how they get to work, to be able to then incorporate all of that in the ways in which we provided guidance and protection for our workers to ensure that, you know, we minimize risk as a result of COVID-19. There's a lot of lessons learned, and I'm sure a lot of more lessons to be learned as this pandemic progresses. But certainly from the race and the racism point of view, it's been a challenge to work against infrastructure that has been put in place and has been looked upon as, you know, the way that things are and should be and the gold standard. And I think it's up to us in public health to really question why it is that these infrastructures are looked upon as gold standards, and to really determine, are they really still the gold standard, or can we do better? And certainly I think that in this moment in time, we can all do better.
So New York City and the tri-state area, and for those who don't live on the East Coast, the tri-state area is New York, New Jersey, and Connecticut, has been the epicenter of, at least initially, COVID-19 outbreaks in the country. So can you take us back a little bit and, you know, talk about February and early March, what your initial response looked like, what you were planning for, and how that played out?
You know, I think that we, like many of us around the country, were gearing up for something that never really came, right? The way in which COVID-19 has played out has been one curveball after another. And I think that we, as many other jurisdictions, were probably over-reliant on testing and took for granted that this virus was going to come to us from one particular direction, namely China, when in reality, you know, we were all working from behind the 8 ball by the time we realized how quickly and how far this virus had already spread. And I think that has been a hard lesson learned for all of us in terms of the degree to which there were restrictions early on who got tested and who didn't get tested. And so there are a lot of things that we did right in terms of the syndromic surveillance, in terms of you know, putting our partners in the healthcare delivery sector on notice in terms of, ensuring their respiratory precautions were in place, ensuring that their staffing was where it needed to be. But clearly on the testing side of the equation, we all certainly fell very, very short.
So you mentioned, we were focused on China and the virus coming from China rather than perhaps Europe. And there's been, lots of public statements about what really wound up slamming the New York area was the virus coming from Europe. How would that information earlier have affected your response? Is it numbers? Is it the speed with which it happened? How does that affect what happened?
So, one of the things that was very clear is early on, I think that I'm going to say something I think a little bit controversial, but, I think it needs to be said. The fact that travel restrictions were only placed on China as opposed to European countries where we knew that there was ongoing transmission was something that we all bought into, and that I think caused us time and caused us lives in terms of really leveraging the kind of response that needed to happen in this event. And so had we been more focused on both flanks, if you will, I think that, and have had testing that allowed us to test anybody who was presenting with those symptoms, I think we would have been in a much stronger place to put control measures in place much earlier.
So, you and many of almost all of your colleagues across the country were really in a position to make decisions in the absence of full information. And I think in the field, at some level, everybody is used to that. We don't have all the data we want all the time. But, it became really acute in this situation in many places. So how do you weigh those decisions when you don't have the data that you wish you had?
Someone once told me that the definition of expert is someone who can make smart decisions with imperfect data. And I think that's to a great degree what we do in public health on an ongoing basis. And I think that being able to make hard decisions in light of imperfect data is what characterizes courageous leaders. And I wish that we across the country had more courageous leaders who didn't necessarily rely on having perfect data, but that were able to make hard decisions with the data that was available. And I think, again, we did some of those things right, and we did some of those things where I wish we had the opportunity again to have more in-depth conversations about, we recognize that you want perfect data, but it ain't gonna happen. And these decisions need to be made now. And these decisions may be ones that will need to change in a day or two. Mm-hmm. But given what we know right now, these are the decisions that we have to make. And one of the things that I learned early on, that it comes down to risk communication and being clear with New Yorkers, which is, I think, something we did on a daily basis to say, this is the guidance that we're giving now with the best data that we have right now. We're learning every day more and more information about how this virus behaves, how people are being affected from a clinical perspective as well as a public health perspective. And we need you to know that we may have to come back to you tomorrow and say, we got to change course because we have new information. And I have been really gratified by the way in which New Yorkers have adapted and accepted that message, right? And I think for me, the biggest example was when we made the decision to recommend the use of facial coverings, right? And we made that decision based on the fact that we had new data come in that documented the extent to which people were transmitting the virus during the asymptomatic period. And so that, was at least a good month and a half, almost 2 months into the response. And so I wish we had had that information much sooner. And it's an example of, having to make decisions with imperfect data.
And then changing the message. I mean, I'll just say, so my kids were like, why are we wearing face masks? You said only people who are sick wear face masks. We're not sick. And, and they're like 8 and 11. So I had to say, well, maybe we are, and you don't know. And so, it goes back to what you said about effective crisis communication and people being willing to hear that the message is changing. So we've heard a lot about the mental health of frontline workers. And I think in the media in particular, a lot of that has focused on doctors and nurses. What I'm hearing, and I'm sure what you're seeing, is that that's also public health frontline workers. And, there are real implications for folks who have been doing this 24/7 for 3, 4, 5 months now. So what have you been doing with and for your team? And, what are you seeing as everybody continues to just work in the response to this?
That's a really important question, and I'll start by answering it in a previous disaster that I was involved in responding to, right? A couple of years ago, there was Hurricane Maria that affected Puerto Rico, and it affected the entire island, and we went down there to provide support, and it really struck me as to how frontline responders, including people in public health, were not only having to respond to the emergency, but having to then go back home and deal with, the consequences of this massive, devastating hurricane. And I think I never thought that I would be a part of a similar disaster playing out, in that not only are we responding every single day, but then we have to go home and, be with our families, talk to our children about what this means. And I think for me, it's been critical for me to show up as, first and foremost, Oxiris, right? Not to show up as the commissioner, not to show up as Dr. Barbot, but to show up as Oxiris, and to acknowledge that this is having consequences beyond what we could have ever imagined, and that on an everyday basis, people are being tested in ways in which we never anticipated. And I recall specifically saying to one of my leadership staff that we needed to partner with the hospital system, because we were having nurses and doctors really work in war conditions that they were not prepared for. And, we stood up a mental health response system for the healthcare workers, but at the same time, needing to create that space for our public health workers who were experiencing vicarious trauma as they were on the phone talking to nurses that were working in intensive care units, or doctors that were working in, emergency departments, desperate for PPE, and having to hear that call after call, and the human toll that takes. And so what we have done is a couple of things. One is, in our incident command meetings, we carved out time to let people sort of reflect on what they were hearing, what they were seeing, and how that affected them personally. We At the end of every meeting, our incident commander, who's my deputy for disease control, and he reminds folks of the importance of random acts of kindness, that no matter what you're going through, there's probably lots of other people who are going through the same, if not more. And then lastly, creating opportunities for our staff to come together virtually and to create support networks. One of the real gems that we have that not very many other health departments have is that half of us is the mental health department. And so our colleagues in the mental health division have been extremely helpful with regards to ensuring that from an external perspective, we always center the mental health aspects of dealing with COVID for the public, but that internally, we do the same for our staff. The last thing I'll say is that every day at 10:05, we have a moment of silence for all of those people who have died in New York City because of COVID-19. Tragically, we are at over 20,000 people that have died because of COVID-19. And, that takes a toll.
Yeah.
We've also created a memorial page on our internal website. We have roughly a dozen health department staff that have died because of COVID-19. And so creating opportunities for our staff to have that collective grieving process is important. And then lastly, what I'll say is that with regards to the mental health supports, it's engaging our staff in understanding in a more granular level what they feel they will need when we start having people coming back into the office. Because ultimately, their mental health and their mental wellness will to a great degree be contingent on the degree to which they feel they have control over their environment, over their ability to protect themselves and their families. There's a lot of layers to it.
Yeah. So we started by talking a little bit about racism and health equity or inequity. Like other big cities, New York is incredibly diverse. So how does the makeup of your community affect what you need to do in a response like this? How do you work on the response, sort of in the immediate, but then also, as you talked about, the fact that so many Black and Brown New Yorkers were dying at higher rates than white New Yorkers?
A couple of things that we have already put in place. I would say that first and foremost, we don't take for granted that the fact that we're saturating the airwaves with corona messages is going to reach every community. And so early on, we have done robocalls, we have done direct mailings, we have partnered with local ethnic media to ensure that our messages are targeted to communities that are seeing disparate numbers of people affected, hospitalized, and dying. Beyond that, we have also looked at the 27 communities with the highest burden of cases, hospitalizations, and deaths, and are partnering with community-based organizations to have them be amplifiers of our prevention messages. We have stood up a community advisory board that gives us very detailed feedback on the way in which we are going to be doing the suppression phase of our response to ensure that it is not one that is punitive or over-policing, if you will, of certain communities, but that is one that's done in collaboration with communities. We are being very mindful of the degree to which social determinants of health, such as unstable housing, such as relying on service sector jobs, really contribute to an individual's and a family's ability to do what's in their best interests, which is to safely separate in their homes. And so as a result of that, we have thousands and thousands of hotel rooms where individuals who are not able to safely separate in their homes, either because they're living in an overcrowded situation, or they're in a domestic violence situation, they can have outlets and safety places to go for the duration of isolation and quarantine. I think all of those things put together really highlight the fact that without an equity approach, without a racial lens to this pandemic, we would not be able to bring the transmission to the point we need it to be in order to lift social distancing restrictions. And one of the things that I've been saying all along is that this has been a really, I think, painful wake-up call to the degree in which we are all interrelated and interdependent. And rather than fight against that we need to embrace it and to recognize that we as a city and as a society are only as healthy and as safe as our most challenged neighbors, and that if we need to do more to make sure that those individuals are safe, then that's what we need to do to ensure that at the end of the day, we are all safe.
Yeah. So we have some questions coming in, and also some that were on my list. So we'll take a few. So there's a question about whether or not there's a specific outbreak, pandemic, or response control team within the department before the pandemic. I mean, I know you all have plans, but how do you sort of move from the plan to the response, and what did that look like?
So we have the way in which the organization is structured, we have a division of disease control. Within that division of disease control, we have a Bureau of Communicable Diseases. They do ongoing disease surveillance. They have epidemiologists that do outbreak investigations for anything from like hepatitis A to, you name it. And that's sort of the nexus of our disease response. In the event, however, of a huge event like COVID or Ebola or whatever it was, we then activate our incident command system, draw on epidemiologists from the rest of the agency to contribute to that surveillance. So for example, we have folks that do that through the schools, through other potential avenues of transmission. We have an environmental division that contributes to this. I will say that this is the longest activation that we have had, and that currently we have had roughly 1,000 people working on this response.
Wow. So we have a question about what plans are you making now related to both sort of a second wave of COVID, and then, hey, also it's probably going to be flu season, and what does that look like, and what are you guys thinking about?
So we have already started on our flu plans. We have significantly increased the number of vaccines, flu vaccines, that we order ahead of time. We have already had conversations with medical partners to ensure that they have contracts in place with more than one vendor for their flu vaccines. We are looking at policy initiatives to ensure that through the state legislature, we're able to have things put in place to make surveillance easier. So for example, requiring that adult vaccinations for flu get reported into our central immunization registry so that we have clear sight into coverage of flu vaccination by community. And then we are currently in the process of developing educational campaigns to maximize the degree to which New Yorkers get vaccinated for the flu vaccine. We are gearing up for what we anticipate will be our biggest flu vaccination season, which will also entail, for example, having contracts in place with medical providers who can, do the equivalent of small-scale vaccination pods. So that is already in the works. We are going to start early on that because we don't want to be in a situation where, from a number of different perspectives, an everyday New Yorker develops fever, cough, and malaise and has the anxiety of, is this COVID or is this the flu? Beyond that, we want to make sure that we do everything possible to minimize any unnecessary surge that occurs in our hospitals because of flu. So all of that has already begun.
Okay, so now the questions are flying in. So I'm gonna, just to piggyback on that one, there's a question about, do you expect that providers will be testing for both COVID and influenza at the same time when patients present with flu-like illness?
Yes, so currently we actually just released a health alert, which is, we call it the HAN. It goes out to all of our clinical providers in the city. It's like over 10,000 medical providers, and the guidance to them has been to test any and all New Yorkers that they are seeing, irrespective of whether or not they're showing symptoms. And I anticipate that for the foreseeable future, the recommendation will be to test all New Yorkers for COVID-19. And so certainly within influenza season, the expectation will be that they will be doing not only the influenza test, but certainly the COVID-19 tests.
Okay. We have a question about vaccine hesitancy, which we've talked about before, and you have some experience with the measles outbreak. I'm
starting to wonder if I'm like some bad omen where tremendous outbreaks follow me.
Lots of folks have pointed out also that this is going to be a brand new vaccine, which might make more people hesitant. So what are you guys thinking about? What are you planning for? How are you going to try to overcome that?
One of the things that we were able to put in place as a result of our measles outbreak and the community partnerships that we built on was a group of individuals from communities where we do see high vaccine hesitancy to give us feedback and guidance about ways in which we can more fully engage individuals to learn about how we mitigate fears from a new vaccine. And so those conversations have actually already begun. We are working on developing messages and approaches and cultivating trusted messengers to ensure that when we get a COVID-19 vaccination, we won't be starting from square zero in terms of maximizing the number of people that get vaccinated. But it's a very real thing. And certainly, to tie it back into, the conversation that we started with regards to racism, it's a very real thing within the African American community, and rightly so, the distrust that they have of the medical establishment, given things such as the Tuskegee experiments and what, the developments through Henrietta Lacks and all of that happened. And so we are painfully mindful of that and are having conversations now to ensure that we provide opportunities for dialogue, for development of educational materials to maximize the number of people that get the vaccine when it's available.
So we have a couple of questions sort of relating to reopening, a term that I am not super fond of, but we don't need to go there. But, you know, I know that next week, I guess you guys are starting to open up the city a little more. There are some questions about public transit and schools. So, you know, we could talk about that for an hour, I'm sure. But, you know, sort of give us some highlights of the various moving pieces, if you can.
For me, the central aspect of reopening, and I agree with you, it's a loaded phrase. The central messages for New Yorkers will be, in my mind, three things, right? It's time, space, and infection control. Meaning that infection control, I anticipate that New Yorkers will continue to have to wear face coverings until we have a vaccination and until we have a significant number of New Yorkers vaccinated. So that could be for at least another good, 6 to 9 months, right? So that reminding New Yorkers that no matter where we are in terms of reopening or restricting the social distancing, we need them to continue using face coverings, hand hygiene, staying home if they're not feeling well. And then the issues of space and time being that we still want them to have at least 6 feet of distance between them and their fellow New Yorker. And that to the extent that they're able to do that, that will then dictate the time that they're able to spend, right? And so if you're not able to spend to have the 6 feet distance, then we want you to limit the amount of time that you're in contact with that individual. So then beyond that, we're working with our state partners to ensure that we have guidance materials on our website about worker safety, about how a business can ensure they have measures in place to protect their workers. I think, again, for the foreseeable future, we want New Yorkers who are able to telecommute to continue to telecommute. We want businesses who are able to allow workers to stagger their work hours, allow people to stagger work hours because, we, unlike a lot of other cities across the country, have a system of public transportation that a lot of people have to rely on, and there are safe ways in which they can use that public transportation, and there are a number of different precautionary measures that we need to make sure are adhered to even more stringently as we begin to release some of these social restricting measures.
So there's a question here about what do you think the long-term impact of COVID-19 will have on public health and health departments?
Wow. Yeah, I think that's an amazing question. I think the changes will need to be profound. I think that the changes will have to force us to look at the way in which we build our public health infrastructure, how we staff both local as well as state health departments, the way in which we all communicate or don't communicate. I think that the degree to which we focus more on equity, I think will be even more apparent, and the degree to which we incorporate mental health into everything that we do, I think has to be front and center. I also think that, it's an opportunity for us to push the envelope. One of the things that I've been pushing my staff and myself to do is to really question why it is that certain things are the way they are. And I'll give you a specific example. We recently put into place a methadone delivery system, right? Because rather than have New Yorkers go to a clinic, travel, who knows how far to have to go to a clinic to get their methadone. We are taking it to them, whether they're living in a shelter, whether they're living at home. And so it brings into stark relief, like, why is it that methadone is the most highly regulated medication we have in this country? There's no reason for that. And really push our leaders to change these artificial barriers, a lot of which have been developed out of stigmatizing beliefs, out of racist beliefs, to really push the envelope. The other thing is, for example, to question why is it that we still have employer-based health insurance? Why is it? Doesn't make sense. There are millions and millions of people that have lost their jobs through no fault of their own, that are now left hanging because they don't have continuing access to healthcare, to health insurance. And then lastly, I think with regards to public health, it forces us to really call the question on the bridging of public health and healthcare delivery. Doesn't make sense anymore to continue pouring billions and billions of dollars into a healthcare delivery system that is not serving all of our people, and that we have to question, why is that? And we have to question and push for more resources for public health.
I feel like we should end there, but I'm going to ask you one more question because there are a couple other questions. But
I'm getting worked up here.
All that. What about sort of specifically on the preparedness side? So there's a question about, what do we need to think about in changing our preparedness? And, I'll sort of side note, I've had conversations with folks who are worried that we're going to have sort of a 9/11 response where we just pour money into preparedness and, pour money into infectious disease, and that's not actually going to solve all the problems we need to solve. So how do we manage needing to fix what we think needs to happen in preparedness, but then also making sure that we're not so, tunnel vision, that we're really building a system that can keep everybody healthy and safe no matter what the challenge is?
I think certainly COVID-19 has shed light on the fact that preparedness doesn't just mean having the right data infrastructure in place, though that is critical. It doesn't just mean doing, let's say, secret shopper visits to emergency departments and making sure that they have the right respiratory precautions in place, that it goes way beyond that to really highlighting issues of supply chains and how it is that there is visibility across partners, be they city or state, with regards to how we supply PPE, that it goes to how it is that we mobilize our social service sector to provide the wraparound services that are critical when addressing, these infectious disease events. It is, I think we will need to redefine what preparedness means and to have a much stronger focus on resiliency and acknowledging the fact that resiliency doesn't mean necessarily just the ability to bounce back, but it means the ability to withstand and to not have the degree of assaults that certain communities have as compared to others, because they are starting at such a different level. And that then takes us back, to the equity and the racism conversation that we will need to ensure is incorporated into any preparedness conversations and planning.
So I think that's a good place to end. I mean, I will share that my own concrete example of that is, so for the first, leading up to the real outbreak here, we were a little behind the curve here in the DC area. Every time I went to the grocery store, I spent $200 to put food in my freezer because I had the luxury of being able to do that. And then I would come home. Now I'm way oversharing with, 75 people. And I would stand in my kitchen and explain to my kids, I just spent $200 at the grocery store that many people don't have. And they'd be like, what are you talking about? You're crazy, Mom. But, you know, these are real life things that are very, in some ways, very minor, but in the middle of, you know, these emergencies, really not so minor. So thank you so much. This has been amazing. Gabby's gonna pull up a slide. I wanna let everybody know that this is a series of conversations we're doing. Our next one is 2 weeks from today. With Muntu Davis from LA County. We will be following up with a scheduled date for July with two of our members from San Antonio and Maricopa County, which is right outside of Phoenix. In addition to this webinar being on our website, the last two, which were Seattle, King County, and then two of our Bay Area, California members launched it for us a couple weeks ago. They're all on the website, so they can all be viewed after the fact. So Oxiris, thank you so much. It was great to see you. Thank you everybody for joining, and we look forward to more sessions. Thanks so much.
Thank you.
Bye-bye.